just extra people can join while we do the bios. Okay, so welcome to this British Pain Society webinar. We're joined by Live Well with Pain tonight. As usual, I'm Graham Dunthorne. I chair the Primary and Community Care Specialist Interest Group with the British Pain Society. So just our little intro that we usually do. This is a little bit about the BPS. It's the oldest and the largest UK multidisciplinary pain organisation, a community of professionals treating and researching pain collaboratively with people living with pain. Championing person-centred approaches to pain care, advocating for better pain care with policymakers, advancing education with training, guidelines and resources, and promoting research to improve the understanding and the treatment of pain. Just drawing your attention to the annual meeting, the annual scientific meeting, which is this year taking place between the 21st and the 23rd of April at the Harrogate Convention Centre, and it would be lovely to see you there. So just a little bit of housekeeping then. The idea is that the session will be 1 hour long. So soon we'll do some bios, introduce Live Well with Pain, and they will take the webinar away. Around about 6:45, we will stop and leave some time for a Q&A. So please, if possible, don't put your hand up or put questions to the panel during the session, but if you could pop those questions into the Q&A, then Satish Singh will be leading the Q&A session at 6:45. We will put this back up at the end with a QR code and would be really, really grateful if you could give us some feedback about the session, as that really does help us to plan future sessions and see the sort of things that people would like us to put on. Okie dokie. So that is that out of the way. And once again, a massive thank you to, I'm just going to stop sharing those slides so that Live Well with Pain can do that. A massive thank you to Live Well with Pain for joining us this evening. The session's been quite a while in the making, and it continues our series of trying to get the big organisations from around the UK who are involved in delivering education around chronic pain and self-management to give us a webinar through the Primary and Community Care SIG. So personnel changed a little bit because of last-minute illness, so thanks so much for still turning up and doing the session. So we have 3 people joining us from Live Well with Pain tonight. Full disclosure, I am also a Live Well with Pain instructor, but I'm not giving the session tonight. So Dr. Emma Davies is a principal pharmacist for pain, analgesic stewardship and harm reduction at the, I can't even say that, I'm so sorry, Emma. You'll have to fill that in for me later, where exactly she works. She has worked in pain management since the mid-2000s, developing her interest in analgesic stewardship and supported self-management whilst working in the multidisciplinary Southampton Pain Service. Emma provides pain management support in primary and secondary care, working with medical teams, pharmacists and the wider MDT. Emma also teaches at undergraduate and postgraduate level and develops guidelines and educational materials locally and nationally. She was lead clinical author for All Wales Analgesic Stewardship and Prescribing Guidelines and a committee member for NICE Guidance on safe prescribing and withdrawal of dependence-forming medicines. Emma co-founded Live Well with Pain, the Live Well with Pain website, with the plan of improving support for professionals and supporting people who are living with pain. So we also have Tim with us tonight. A former teacher, Tim serves as Vice Chair of the British Pain Society's Expert Patient and Carer Committee, is a trustee of the charity Pain Concern, and a patient representative for the Physiotherapy Pain Association. As a writer, Tim has shared insights from his personal experience in his book, Where Does It Hurt? In addition, Tim is a lived experience trainer with Live Well with Pain and edits the organization's regular newsletter. We also have Rachel with us tonight. Rachel is a specialist physiotherapist in pain, working as a facilitator with Live Well with Pain. Rachel also holds the position of co-chair of the Physiotherapy Pain Association. After qualifying in 1993 from Manchester, Rachel specialised in musculoskeletal physiotherapy. Rachel has worked in the NHS across both community and tertiary settings, in industry with occupational health, and in the private sector, in hospitals, and in running her own private practice. Encountering many patients with persistent pain prompted Rachel to explore various resources and attend numerous courses before undertaking an MSc in pain science at the Society of King's College London. After completing the MSc, Rachel moved to specialist NHS pain services. Before joining Live Well with Pain, Rachel was the lead physiotherapist in the facial pain team at the Eastman Dental Hospital and an advanced practitioner physiotherapist at University College London Hospital Pain Management Centre. Rachel has a particular interest in orofacial pain, the role of movement in pain experiences, as well as the neuroscience of pain. Rachel is committed to advancing the understanding of persistent pain, sharing knowledge, and supporting healthcare professionals in the field. Central to these interests is the belief that improving knowledge and care will enhance the lives of people living with long-term pain, which increases their access to quality support and encourages their involvement in developing services. So that is our three speakers tonight. Apologies, Emma, for a complete failure in being able to pronounce Welsh places. I'll let you take over on that. I am going to turn my camera off now and move to listening. And then when we finish around about 7:45, Satish will take over and run the Q&A. Thank you.
Thanks, Graham. I'm just going to step in before Rachel starts to say I work for a health board called Cyntaf Morgannwg, which is in South Wales and is basically the bit between Bridgend and Merthyr Tydfil. And that's all I'm going to say on that. Over to you, Rach.
Thanks, Emma. Thanks, Graham, for the introduction. Good evening, everybody, and thanks for joining us today. And thank you for the invitation by the BPS. As Graham said, I'm Rachel Stovell. I'm a specialist physiotherapist in pain, and I'm joined by my very esteemed colleagues, Emma Davis and Tim Atkinson. Although we have stepped in at short notice, and sorry that you might have been led to believe that other people would be with you, but we're reasonable stand-ins, and we're really, really pleased to be able to share what we understand by supportive self-management and what that looks like in practice, and we hope to give you a reasonable insight to what we do and how we do it with Live Well this evening. So the idea and the learning objectives today, we're focusing really on three areas. What effective person-centered self-management support is, that it's grounded in NICE NG 193 and also in NHS personalised care. The key components of implementation is another theme. We're looking at planning, commissioning, building skills, confidence and meaningful evaluation. And then lastly, we're hoping to give you examples of integrated approaches already being used across the UK. We'll keep things practical, realistic and hopefully anchored in what it's like in everyday clinical practice. So those are the things that we're trying to sort of get across this evening. I'll let Emma continue.
Thanks, Rach. So we're going to start by thinking about some of the common factors that shape a person's experience of living with persistent pain. And this is a lot of where the resources from Live Well with Pain come from, really. So this is a horrible slide, but I think what it does is illustrate just the myriad factors which impact and affect a person's experience. But they can be broadly broken down into three parts. So firstly, we tend to think about things like practical and environmental factors. So that might include things like transport difficulties, housing, limited access to having adaptations made to where somebody's living or working and how that affects their ability to manage their pain. And those barriers can make it really hard, sometimes even just for people to attend appointments or engage in physical activity that we might be trying to encourage them to do. And it can be a real barrier, particularly to considering lifestyle changes. So the thinking about that means that we really need to adapt our approach. So it may be practical things that we can do out in practice, such as offering remote appointments if people find it difficult to travel, connecting people to social prescribers who can provide that support around housing, benefits, transport issues, ensuring that as much as possible, we recommend community-based options for people because they tend to be obviously local, but more accessible as well. And we can use them to adjust goals so that movement and activity that we might be encouraging becomes something that just develops into an existing routine rather than something which is foreign and only done in a special place. The second thing to consider around emotional, cognitive, and health-related factors. So when we're thinking about that, we're possibly considering things like depression, anxiety, but also fear, shame, frustration. These are really common things that people with pain report experiencing. And of course, alongside that, you get fatigue, effects on sleep are really significant for people living with pain, and just overall reduced energy. And of course, that then affects everything else you're trying to do. So that can also then affect the experience or influence how ready somebody is to actually engage in self-management. So if somebody is just exhausted, frightened, overwhelmed with everything, expecting them to just do more, which sometimes is the message, just isn't compassionate for a start, but also isn't likely to be effective. So a lot of our resources in Live Well and our ethos is around shifting from instruction to supportive coaching and helping people to understand their pain better, trying to reduce the fear that's associated with it and recognize progress when they make it as well, rather than feeling that everything they do is a failure. Then the last factor to consider is around social and identity related factors. So here we're talking about things like reduced contact with family, friends, social networks, loss of work, roles, purpose and identity. And there are challenges for carers as well as the person living with the pain themselves. And we know that persistent pain can shrink a person's world. So often their world becomes smaller and therefore pain dominates or feels like it's dominating much more. So, and that's why it's so important to address loneliness and that loss of identity especially. So in terms of thinking of our role then as practitioners and how we support people in those circumstances, we're thinking about meaningful activity, what really matters to people and what do they want to get back to doing? What are their supportive relationships? Do they have them? Do we need to help them form them? And that's where community groups, peer support, shared experience comes in. So this is why we're seeing this rise in social prescribing, peer groups, pain cafes, community activities. All of that can be really transformative for people. So although that slide is pretty horrible and it looks like just a massive long list of problems, what it hopefully demonstrates is that persistent pain is a whole person condition. And when we understand those barriers, we can adapt the approach, remove some of those obstacles, and offer support that really fits into the person's life. So that is the foundation, as we believe, in Live Well with Pain, of genuine person-centered supported self-management. And that's the reason that we try to make resources which are flexible, compassionate, and collaborative for the people using them. Just going to quickly say a few things about the World Health Organization definition of self-care. It sounds like quite a simple definition, but obviously it has big implications for actually how we work with people living with persistent pain. Again, we can break this down into sort of three main areas. So self-care is something that people are often already doing. And one of the most important interventions we can make is actually help people to see that for themselves. So people often feel when they present and are living and struggling with pain that they're just not getting anywhere. They're not doing anything. If you say, what are you doing to help manage your pain? Often they're doing quite a lot, but they don't recognize some of the things that they've started to do or learned to do over the years. They don't recognize that as part of their self-management. And it's really important to tell people that and point it out for them because they're already doing it. And so when we start talking about self-management, it isn't something new, it's something they are already doing. So, and of course, our role isn't ever to just tell people what to do. Taking a coaching approach is about noticing these things that people are doing, validating it, and then helping them to build on that. Self-care also doesn't mean self-reliance. It means supported autonomy. So this is one of the biggest misconceptions perhaps about self-care, is that it means doing everything on your own. And I think sometimes that is the message that comes across when people perhaps present to some pain clinics and it feels like it's the end of the line. And now everyone's tried everything else. I've tried all these medicines and now I'm just being told, get on with it. But actually, that isn't what supported self-management is about at all. The WHO definition makes it really clear that self-care happens with or without professional support, and we think it's better if it happens with it. So instead, this idea of supported autonomy is about the person making informed choices about their health with us as the practitioners alongside them as partners in that process. So emphasizing things like shared decision making, personalized support plans, and as I've said already, coaching is a really important factor in that. And then the final thing is around effective self-care requiring skills and confidence and supportive systems. So again, this isn't saying you just got to try a bit harder. It's about understanding what people need. Do they need information? Do they need reassurance and validation? Do they just need some practical tools that they can put into play? So this is where I think a lot of our work in Live Well with Pain comes in. We try to support people, both practitioners and people living with pain, to learn the skills to pace, plan, relax, sleep better, to build the confidence in using those skills and trying new approaches, and then trying to connect in systems of support. So again, from things like social prescribing to peer groups. So that this WHO definition reminds us of something really important then, that self-care is not a passive concept, it's active and supportive partnership. It's about enabling people to navigate their condition with confidence, with us alongside them, not above them. And when we do this well, self-care helps people feel more in control, reduces the impact of pain on their daily life, and supports their overall well-being.
Great, thanks, Emma. So this slide starts to demonstrate some of the use of some of the skills that we have with Live Well with Pain. So initially, we're looking at trying to consider what a self-care cycle would look like. How doing things differently might help somebody to be able to live differently with pain. So these aren't abstract concepts. Sorry, is there a bit of a... I think I'm getting a little bit of a problem with my sound. I'm just going to turn the video off.
Your audio, Rachel, yeah.
Is that better?
So far?
Sometimes, yeah, sometimes.
Yeah.
Yeah. So they're not abstract concepts, they're the things people tell us consistently make the biggest difference day to day. And they align very closely with the NICE NG 193 guidelines and also the NHS personalised care approach. So if we look at the themes that run through this cycle, if we think a little bit about initially understanding and acceptance. So this understanding this or presenting this to people can create a foundation for change. You know, one of the first things that helps people reduce the impact of persistent pain is understanding what pain is, what it isn't, what persistent pain is and how it's different from acute pain and how it works. You know, when people learn that persistent pain doesn't always signal damage or harm, that it might be a change within their nervous system, that the nervous system has become perhaps oversensitive or overprotective, and understanding that how we think and how we feel and the other things that might be going on for somebody in life can affect pain as a whole, and that it's within a context that also being active, that movement in itself, whilst it might have an influence on pain, doesn't necessarily mean that there's harm or damage in most cases. Those ideas, bringing this across to people, can help to reduce fear. It might help them then to gain the confidence to be able to do things that they haven't been doing. And that starts to change their sense of control, you know, giving them back some of their own control over the way that they live and how they live with their pain condition. Similarly, acceptance, we're talking in the clinical sense, it's not the sense of giving up, it's more recognizing the meaning that this is where I am now, and these are the things that I can do to influence my own well-being and my own, I suppose, quality of life and what I do in the presence of the pain that I have. NICE NG 193 places a strong emphasis on education and the reconceptualization of pain for exactly that reason. Understanding and acceptance, they create the psychological space for change. I'm going to ask Tim to join us a little bit on this conversation, because Tim and I work quite closely together with the Footsteps program, and we frequently come back to these two themes, don't we, Tim, as to underpinning some of the other things, but they can be sticky in helping people to take on board, can't they?
Yeah, I mean, some of the things are more difficult, and on the Footsteps program, they're structured and numbered numerically and ordered, but there is very much this sense as you work through them that you revisit different ones at different times. And once the basic principles of self-management are understood and accepted, some of the things will be, almost all of the things will be works in progress as you go through your kind of self-management journey, as it were. So, yeah, if that's what you meant by sticky, Rachel, I think that's what I'd certainly echo. It's interesting to hear from the, both of you quoting the documents. As a patient, you know, NG 193 comes over to me very simply by way of medication reviews, which are very simple and aggressive and often done by text or telephone, and which revolve purely and simply around the medication that I've been prescribed for the last 20 plus years. They don't often have any discussion of the fact that it's a collaborative process and it involves pain education, and some of these principles are foundational if you're going to move people away from the reliance that's been built into the system on pain-killing drugs.
Thanks, Tim. It's interesting you say that, and I'm sure it was something that we'll come back to, the idea of giving and supporting before perhaps reducing or taking away makes a lot more sense, doesn't it? But I'm sure we'll repeat that later. Moving a little bit into a thought around sort of practical self-management tools is the other things that perhaps are a little bit displayed in this moving towards a self-care cycle or trying to introduce somebody to a self-care cycle. So it's strategies like pacing, so, you know, the balancing of activity, allowing people to rest but in a helpful way, trying to move people away from a reliance on something like a boom and bust cycle, or even where somebody's activity levels have become so low for fear of increasing pain. Activity planning goes within that, which might be breaking tasks down and moving them into more manageable chunks. And actually, it's quite helpful at this point as well that we talk about goal setting, giving people things that allows them to work towards. But it's really key within the live well with pain approach that we make sure that those goals are meaningful, that they are aligned with people's values, that people are able to set goals that make it more likely for them to continue to work towards them. And that's fundamental in making them something that are important and meaningful in that person's life. We look at other tools like relaxation and mindfulness, recognizing that these things might be helpful in being able to, I suppose, if we like the phrase, calm down that nervous system, to be able to move away from it always being as heightened as it can be, and maybe it's a way of being able to change that. There's also the thought that sometimes living with long-term and persistent pain creates stresses and tensions in addition to the pain that somebody's already experienced, and that may well be felt physically. And then by introducing these things, we may be able to reduce some of that, which might reduce some of that secondary awareness that's going on alongside somebody's pain. Sleep strategies form part of the Live Well approach. There are lots of, we'll come to them later, I think, that we've had lots of feedback that sleep is something that people are commonly tell us is a problem for them, and therefore introducing sleep strategies with the idea of bringing sleep to a more restorative rest can be really helpful. We take notice of mood. Emma mentioned earlier in the previous slide that people are often seen to experience perhaps a number of things with living with pain, but certainly mood changes can show anxiety, they can show anger and frustration, and they can also show quite a lot drop in mood and even depression. So it's really important that we start to explore these themes, notice unhelpful thoughts, help people to build confidence in being able to understand their mood changes and how to work with them, and also be able to reduce both fear and frustration. Each of these skills directly influences the intensity and the interference of pain, and they do help people do more of what matters with less potential setbacks or flare-ups, and also less distress associated with living with this long-term condition. Again, NICE NG193 recommends psychological and behavioural interventions as core elements of care because they help to build resilience, confidence and consistency. Okay, lifestyle and long-term well-being. The ideas behind becoming more active, increasing fitness, nutrition, and how to deal with setbacks and build resilience. The final theme is about sustaining change and supporting long-term well-being. These include perhaps getting fitter gradually, enabling people to be able to explore moving their bodies again in the presence of long-term pain, understanding what that feels like, and being able to do that in a supported way. We have introduced some ideas around nutrition and healthy eating, supporting overall health, and therefore also thinking about the effects that good nutrition might have on inflammation. We think about problem solving and communication skills, particularly assertiveness, and how this might help in the relationships that people have when they live with long-term pain all around them. So that might be family, friends, it might be in the workplace, but it also might be their engagements with other healthcare professionals so that they can take a greater role again and feel more confident in being able to recognise and communicate their own needs. So we're advocating for support or adjustments. In managing setbacks, we recognise that flare-ups of long-term and persistent pain are normal. They're not a failure of somebody's ability to manage their pain. They're part of the condition, and that it's important to bring that in and to be able to help people to think, okay, if these situations are going to happen, how might I be able to work through that in a more helpful way? So with the right tools and expectations, people might then recover more quickly from setbacks, be able to maintain their own confidence in the fact that these things have happened. Again, NG193 reinforces this idea. emphasizing self-management as a long-term iterative process rather than a one-off intervention. And that's the idea of continued self-support as well. Okay, so just a closing thought, when we talk about changing the impact of pain, we're not talking about eliminating pain entirely. We're talking about helping people build a toolkit, a set of skills, behaviours and understandings that gradually increase confidence, participation and quality of life. And when all of these elements come together, people start to feel less overwhelmed by pain and more empowered in their daily lives. And it leads to a greater sense of control, a greater sense of a shift towards them being in control of how they live with this condition. Even if they're not necessarily totally in control of the pain itself, they're in control of how they live with it. I'm going to, before I move on to the next slide, ask for Tim if he has any further comments on that.
I could add very little other than you've summed it up very nicely from my own point of view. You know, the really foundational thing is to appreciate that you've got to switch expectations from, you know, diagnosis and cure to ongoing management. And that level of acceptance isn't easy to attain, but can be worked on and can be helped by things like the Footsteps program and the principles that underline it. And they help in turn to build techniques that enable a patient to gain and improve their mental and physical resilience, but underpinning all of those from my personal point of view. And I think this does, again, figure really prominently in the Footsteps, especially with number one, with pain in the brain being that first step on the ladder, is agency. You know, knowing that it's what you learn. It's knowing about how your pain works that can lead to real and lasting change.
Thanks, Tim. We wanted to perhaps bring together the key elements of supported self-management in this. The approach that underpins everything that we're talking about today is not a single intervention or a single program, but a way of working that empowers people to understand their pain, as Tim just said, to build confidence and to make sustainable change that lasts. We can think of supportive self-management through three main areas: helping people understand their pain and reduce fear. A major part of supportive self-management is helping people make sense of what they're experiencing, validating that they are experiencing it, but coming so that people become less confused, less frightened, less frustrated because the explanations that they've received don't fully connect with their lived experience. Supporting self-management begins with clear, accessible explanations of pain, reassurance about what pain means, reduce of fear of movement, helping people recognise helpful and unhelpful patterns. And when people understand what persistent pain often reflects a sensitive or overprotective nervous system, and then it's not ongoing damage, then their fear starts to change. We're looking at that shift to unlock their motivation. Secondly, we want to build capability, the skills and confidence to make changes. The second aspect is supporting people to develop skills that make day-to-day manageable changes in life. We want to think a little bit as well about the focus isn't just on what the person should do, but on helping find strategies that fit with their life, their values and their priorities. It's all about small, achievable steps are far more effective than ambitious plans that really aren't sustainable. And I suppose creating a supportive relationship system around that person, you know, the final theme is about the environment in which self-management happens. So it might be that they then change the relationship with clinicians, with family, with friends, with their workplace. It might be that they think about how they connect with other people who understand their pain. So maybe that's where supported aspects come in, like pain cafes and other ways of being able to be supported more with people who they understand. So a closing reflection, supportive self-management is about much more than just giving advice. It's about understanding, capability and partnership. Brilliant. Emma?
Thanks. I just was thinking we probably should have said that the one of our major tools that we provide on the Live Well with Pain website is the 10 footsteps. So we've referred to the footsteps. I'm just going to say a little bit about them now. So the footsteps were developed to be a clear and fairly practical framework to help people build those skills that Rachel's talked about and the confidence needed to manage persistent pain on a day-to-day basis. And we started off really by thinking about what practitioners needed in order to support people coming in to see them in a more effective way. We tried to keep the framework as simple as possible and flexible. And as Tim has mentioned, although each footstep is numbered 1 to 10, there's nothing to say that you have to work through them in that order. People come to us at different stages of understanding, of different stages of engagement with their pain or with healthcare generally. And so really, you can use the footsteps to meet the person where they already are. You don't have to start at the beginning if the person already has some understanding. But the idea, if you're starting literally from scratch, is to provide a structured but this flexible roadmap to help people understand and live more effectively with pain. So obviously a big theme, and the first one perhaps, is that understanding. And that's why, as Tim said, we start with pain in the brain. Helping people to understand how pain works helps to reduce some of that fear or correct some misconceptions that they may be carrying with them and which may be holding them back from making the changes that will really make a difference to their experience. The second theme is around this idea of developing practical skills to support their daily life, their well-being and function. And so that's looking at things like, as Rachel's already mentioned, relaxation and mindfulness, sleep routines, communication skills as well, because these are often the areas where people feel stuck or particularly unsupported in the usual care that they've had up till now, but they make a massive difference to well-being. And then building that resilience, and that's a word that we seem to be saying a lot, but it's a really important part of self-management. And enabling continuity, so managing setbacks and staying engaged. Pain is a long-term condition, and people need to have the resilience to keep on managing it over long periods of time. And sometimes things get difficult and they need a bit of support to get back on track. But what we're trying to do through the 10 footsteps is give them as many skills as possible to keep them on that road for as long as possible. So the 10 footsteps is built around this idea of having a shared language, so from the practitioner and the person living with pain, to have, and it's based on structured, evidence-aligned frameworks that clinicians can use from any profession. We have a whole range of people who've engaged with 10 footsteps, but really importantly, that people living with pain can use at home and at their own pace. Tim, so I'm going to bring you in here. So you're a very experienced self-manager, I think we would say.
Thank you.
But also you're an extremely valued and important member of the Live Well team as well. So can you share your experience perhaps in what people with pain need from us as practitioners, and how the 10 footsteps or other Live Well resources may help with that?
Well, the first thing I'd like to say is just to go back to what you were saying with reference to the last slide. Probably the only footstep that is absolutely fundamental and perhaps sort of fixed is pain in the brain, because the most important thing in my experience was learning to appreciate that the chronic pain that I was suffering from was different from the acute pain that I and I'm bound to say most of the healthcare professionals that I've dealt with over the last 30 years of treatment have regarded it. And that once that particular penny dropped, the rest almost began to fall into place quite naturally. I think I'd needed that personally from my point of view. I really did need that pain and the brain science in order to get on board with everything else. Some of the other things can appear a little bit sort of platitudinous and greetings card, hallmark greetings card, sort of good wishes kind of thing, which might have been a little more difficult to accept had I not had that building block of pain science first. So I was very lucky. I accidentally stumbled across the pain and the brain stuff in probably the most entertaining and educating way imaginable when I attended live by invitation one of Lorimer Mosley's sessions. He happened to be in the country about 5 or 6 years ago, and I was invited to one of his extremely entertaining talks. And if you've not seen him, please do look him up on YouTube. And that absolutely was the penny drop moment. Having done that, the practical skills-based approach of the 10 footsteps then fell into place so naturally that I was able to take every step on board with relative ease. Having said that, I will just say, to go back to what I said when Rachel invited me to speak earlier, they are all works in progress. There is never a sense in which I think, from a patient's point of view, you can tick any one of these off, and I suppose therefore that reflects back on what the practitioner has to bear in mind. They're not things that you can tick off and have assume are done and done and dusted forever. I constantly have to revisit most of them. Some of them are better than others, but it's an ongoing condition, isn't it? Chronic pain, and it's I don't know. It's like another chronic condition that I suffer from is asthma. So you have your asthma review. Nobody would dream of these days seeing you once and then saying that was it, you were done for asthma for the rest of your life. It's now more than accepted good practice that you have to have at least a yearly review. You have to have a check-in on these things. So there is this sort of built-in almost a safety net really with the 10 footsteps that involves that repetition, that necessary repetition, and that's why footstep 10 and the need to accept and confront setbacks is there at the end of the ladder, because it's almost like a game of snakes and ladders. Really, the footsteps. You go up the ladders and make huge progress on some things on some days or in some weeks, and then something can just lead you to slide back down the game board and almost go back to the beginning. But because of your previous experience that you're going to climb up and make it a bit higher again. It's a question. I mean, if I was to sum it up, I mean, it would be knowledge, to go back to the pain and the brain thing, sympathy and certainly acceptance from the healthcare practitioners of the reality of our experience. And that is a big supertanker to turn around because of all sorts of issues. Time probably is the best known amongst them, but I'm afraid to say that words matter. As an author, that would be something you'd expect me to say, but the kind of language used sometimes in some of the notices that I get CC'd in from a consultant at the hospital back to my GP at the surgery are less than empowering and completely cut across some of these collaborative approaches that we've already discussed. So you don't claim, the patient doesn't claim to have a pain score of 5 out of 10. That is their report. Believe it. So knowledge of pain in the brain, sympathy and belief, and that will give the patient agency to take it forward.
That's brilliant. Thanks, Tim. I'm conscious of time, Satish. Did you want to start questions? We've got plenty more to say, but I know, and we started a little bit late, but we can stop there, and we're quite happy to go to questions if that fits with your.
Thank you very much, everyone, for that interesting one about supportive self-management. We have got only a few questions which might stimulate some more discussion from the participants. So the first one was from Stephanie Zaret. She agrees that there had been said and represents how we work in our service, but it is harder to change the approach of the health system than the approach of patients. Patients are very open-minded about changing their approach, but in general, the health system seems stuck in a medical model and the expectations of changing pain. So her question is, do we have any ideas how to get the approach of supported self-management as being the norm rather than a referral to a pain clinic?
Shall I take that
Yeah,
to
sure.
start with, if that's all right? To add to that ridiculously long bio, I'm also the National Clinical Lead for Persistent Pain here in Wales. So I can say with some maybe some authority, other people may be the judge of that, that the need to move to this a community anchored self-management approach is absolutely essential. We actually don't have a choice. Certainly where I work in Wales, we are overwhelmed by the numbers of people living with pain. It's over 38% of our population is living with some degree of persistent pain, and it impacts not just their day-to-day life and their working, but it also has a really significant effect on the health service as a whole, because people that are finding it difficult to live with pain are often also finding it very difficult to manage other health conditions at the same time. And we know that many of the skills and resources that we use in pain management can be adapted to other long-term conditions as well. So investing in pain services, investing in self-support is an investment in your population's health. And that's certainly the message that I give in my position as lead. And we are looking very much here in Wales at moving to a model that is based around health coaching and supporting people to learn how to manage their pain better as much as possible by themselves, but with that supportive service built around them. There's already good examples of that. I think we heard just the other week here in Wales from colleagues in Leeds, and they have a service which is anchored out in the community, and everyone that enters that service goes to the community-based service and is supported to learn self-management skills, regardless of where else in that service they go to. So I think we are already seeing that shift, but there certainly needs to be more emphasis on it. Yeah.
Tim, you
I was
wanted.
just going to, I was delighted to see Stephanie's question that her experiences of patients being the flexible people in response to patient and open to self-management and all these collaborative techniques. There is also some onus on us as patients to be open to this. And let's face it, we're all patients and healthcare professionals, products of a system which has been in place over the last, which was in place from early infancy, when your parents first reach for the Calpol bottle, of expecting an immediate chemical solution to a problem. And that is a very difficult societal expectation to change. And it has been my experience mixing with fellow patients that some patients are very difficult to persuade that they can claim back some agency. So I would just like to sort of say that, yeah, it's a two-sided enterprise, isn't it? And we've both got to be working in the same direction. There are patients who will who can help in those endeavours.
I think as well, if I can just come back in, Satish, is to say that I completely understand Tim's reflection about the NICE guideline and how that's actually been implemented in practice. And I think what Rachel was emphasising there is that how it's been put into practice and what it actually says are often absolutely not the same thing. And there's a lot within the NICE guidelines that would actually support organisations to change how they deliver pain services if they chose to do that. And I think we need to have much better advocates from a pain management perspective. So I'm talking about professionals here, to actually explain to commissioners in England, to health boards in Wales, etc., why it's so important that we make that change. And not just so we're aligned with NICE guidelines, but because it benefits the population. And it is a real shame, but not necessarily a surprise, that about Tim's reflection that often NICE guidelines are just used as a stick to beat patients with, and to make changes to something that appears simple like medicines. But you can't take medicines away if people have nothing else to put in its place. And that's where self-management and proper support comes in.
Thank you. There are a few more questions. I'll go in order. So one is comes to the panelist without the name, so the person can ask if they have got any additional questions. So how can clinicians ensure that self-management plans for people living with persistent pain are genuinely person-centered rather than service-centered? I think it's kind of an overlap kind of things. So I'll open that to the panel. I think Rachel wants to answer that.
We'd certainly say one thing that from my own practice and having worked and then shifted to working with Live Well and the way things that have gone with my other role in the PPA, one thing is to include the people that you're trying to work with in the building of your service. So if you want something to be for them, involve those people. Develop a service, develop an approach that is collaborative, bring them with you, ask them what they think they need, ask them the style, have people on board, make it a collaborative approach, make it a co-production. Don't leave people out. We're all very good at saying, I think this is what they need. Well, how do we know? Why not ask them? Bring them on board, ask people with pain, what do you think would work for you? And that's certainly something that Live Well with Pain, we're much more advocate of now. I think things have changed. I think there's a big shift, but I think that needs to continue. So if you want people to carry on, if you want them to join, ask them what they want. Tim?
Just also, you certainly couldn't agree more with asking people what they want. And in terms of the people, and I was that person perhaps 10, 15 years ago, who aren't sure or who maybe don't know how to articulate it clearly, sell this to them. It's very much a case sometimes that all these self-management techniques are laid on the table, and then the patient is again blamed if they're not actively engaging with them on the basis of one very brief consultation or a few fired off emails. Now, if you're a car salesman, I don't know, or whatever else, you don't blame the customer if he doesn't buy your car. There is a job of sales to do, and I know we're talking about time pressure in appointments, and I know of all those difficulties, but really that investment in time in the initial stages of treating somebody with long-term pain will pay dividends galore further down the line.
Thank you. There's a couple of questions from Sonia Atkins. So Sonia has been running an organization which has been delivering supported self-management for 38 years. She had been seeing more and more health boards choosing not to incorporate services due to budget cuts. So her question is, if we know it works so well in the long term, why is it not seen by board as an investment? And following on from that, how do we better evaluate the service?
Silence.
Who's going to jump in on that? I'll spare Emma's blushes and say Live Well does a great deal of empirical evaluation of the success of the programme, which is all available in published data. So there is some very valid and convincing evaluative data there to support this. But I don't know, budgets aren't my thing. I'll let the professionals speak on that.
Yeah, I think the budget issue sometimes is a myth. I think we actually have a lot of money tied up in health services, and it may be that the issue is it just isn't allocated in the right place. So pain services, particularly the traditional setup of pain services, are actually quite expensive to run. If you're running a fully functioning multidisciplinary pain service, they're pretty pricey because you have a lot of sort of highly graded people within that service. And I think that what we have to understand is that we can reallocate those people in a slightly different way. So we don't need to have a lot of new finance into services. I suspect if it's anything like where I work, where I'll be honest, we don't have a particularly great pain service, but we have all of the elements for a good pain service. They're just not working together at the moment under a single banner. So they're very difficult to find. And I think sometimes that's a conversation we need to be having, is we need to be looking at what do we have available? How do we make it work better? Because I think in most places that probably there is a lot of that there. Sonia is, I'm going to get the charity wrong, but I can see Sonia in my mind's eye. And I think organisations like Sonia's and others working in third sector are absolutely vital for some of this. We have some amazing support and skills and expertise out in the third sector. And I think that traditionally the NHS and services have been really poor at integrating that third sector expertise into their offerings and working with third sector organisations. And that, again, can free up a lot of resource and support for people. And we need to use that better as well.
Thank you. A couple of questions. I think it has been partially answered in a way by the panelist, and it's gone into the chat. I think it's from Graham. It's like, what do you think are the greatest priorities in today's NHS to support people living with chronic pain? And the other one is about the patients who really doubt the role of self-management and how we can support them. So I think it has been partially answered, but I'll be happy for you to answer if that's possible.
If I can just say something there around this idea about people being reluctant to self-manage, I think a big part of that is because of where currently that comes in terms of pathways and where that conversation starts. At the moment, it comes in far too late. So really, when people present with acute pain, because really chronic pain starts acutely, and it doesn't start long term, it starts and then it continues. And we need to change that experience right from the outset. So when people present for the first time, we need to plug them in to self-management and get them thinking about pain and how to live with it effectively from that point, not wait until they're 5 years down the line, have seen every possible specialist and feel completely disheartened and abandoned by the system. And that at the moment is where this idea of self-management comes in. And it's too late then for some people, or it's much harder to engage people at that point. So starting that conversation early, and that's why Live Well came in really, because we recognised there was a big gap out in primary care, who ends up responsible for all of this, whether they want to be or not. But people are always out in primary care, so it's the prime place to have that conversation and to start that thinking process with the patient. And I think that would be the biggest change that we could possibly envisage, would be to say that conversation starts at the first appointment and you repeat it every time the person comes back. And that's how you break down those barriers and get people engaged.
Please, Tim.
Yeah, I couldn't agree more. And again, just from a non-clinical background though, is there any clinical reason why the self-management techniques that we know work can't be introduced even at as early as a first appointment in conjunction with or as an alternative to the prescription of analgesics? We know these things work, and therefore if they work for chronic pain, they're likely to work to some degree for acute pain. I mean, we're not talking about some of the extremes that might require instant medication. But I agree with Emma. The earlier these things are introduced, the earlier these suggestions of self-management are introduced, the earlier people's minds are opened to the way their brain can become stuck on amplifying pain signals, the easier it will be further down the line for them to make a success of self-management.
There are a few comments in the chat from Heather as well as Olamide Olukoga. I think I pronounced that. He mentioned about too early in the acute phase as patients cannot take message on board that early and pain may settle with medications. And also to tell patients they will live with pain in acute phase as some resolve chronic pain after 6 weeks or 3 months. So those are the things. Now,
Well, yeah, sorry, if I just can I just address both of those? Because
yes,
from a
please.
patient's point of view, yeah, of course, if you're going to tell somebody that they've got to just suck it up, which is what I kind of maybe misinterpret one of those comments as meaning, you're not going to get any cooperation. But secondly, I mean, there are patients in acute labour pains who are given non-analgesic interventions which have empirical evidence to support their effectiveness. Hypnosis, for what?
I don't think it's about saying this is when you see somebody in acute pain that you start talking about chronic pain. But I think, as Tim says, many of the techniques that we use in chronic pain are definitely helpful in acute pain as well. And I think that sometimes that division between acute and chronic isn't particularly helpful, because everybody's experience of chronic pain is that it started. And as I said, when it starts, you don't know how it's going to end. So we have some pointers. So ideally, if somebody's got acute pain following surgery, we hope that as they heal from the surgery, the pain dissipates as healing progresses. But for some people, that isn't the case. But I think that it's about the message that you're giving. So things, just really simple stuff, remain active, even if it hurts. That the likelihood is, unless your leg is hanging off, you're not going to do yourself more damage. So we wouldn't say that in someone who's just come in having a car accident and say, well, you've got to keep moving, when they're literally broken. But it's about giving them the information that as you are able, you need to start moving a little bit more. And that, and using pain as the pointer, that if you get to a point where it hurts too much, that's the sign to stop. But it's those messages about activity, about managing your medicine sensibly, that these are to help you with movement, not to take pain away. Because often people's ideas around their persistent pain are formed from messages they were given when they had acute pain. And so that's why we need to get that messaging changed from the outset. So it's not about being a doomsayer and saying, oh gosh, this is it forever. Absolutely not, because I don't believe that when I see people with chronic pain either. I always believe that there is an improvement that can be made and that things can get better.
Thank you. If anyone has got any questions, please post them in Q&A. And there is an evaluation form in the chat, so please fill it in. That will, as Graham was saying, will help us to improve our webinars in future. And just one question which I had for Tim was, as a lived experience, you had your pain in the past and a chronic pain patient. You mentioned something about primary care services, about text and messaging your medications, as well as the reviews, which don't happen. So any pointers to our primary care colleagues from other side of the table, Tim, as a patient?
Yeah. Try and implement the full recommendations of NG 193. Sorry, it was slightly facetious and it was off the cuff, but my direct experience since the update of the NICE guidelines has only been a text message saying I need a medication review and a phone call with one of the pharmacists attached to my GP practice, which has been less than satisfactory. Had I not been, somebody who was already well down the self-management road and was just somebody who was being told, well, you're on these drugs and we're now not going to prescribe them anymore, and you shouldn't have been on them in the first place. There's very much a kind of sense of you naughty boy, who gave you these and why are you still taking them, which is utterly and completely counterproductive to the principle of agency and collaboration that we've spoken of, and which comes through time and time again. The NICE guidelines don't recommend, they're guidelines, they're not tram lines. They don't recommend that everybody has to come off all their medication. It just recommends that things aren't instigated without good cause, and that things are reviewed in the light of evidence and in the with respect to the benefits a patient might gain. But I'm afraid my personal experience, which may be an outlier in terms of being at the negative extreme, is that all I've ever had is no way, absolutely not. And it's been very it's been totally, if I was somebody who hadn't already come on board and worked with Live Well and knew all about the other techniques and practiced them sort of daily, I would have been in an awful position, because I would have had the rug well and truly pulled from underneath my feet without any other support whatever. Furthermore, I'd have been coming away from those brief telephone consultations with a sense of being totally in the wrong for doing what my medical practitioners have been telling me to do for the last 30 years. It's almost as if I've been an illegal sort of street user. Ridiculous, absolutely ridiculous. And as I say, the messages that come back through the CC'd notices that I get from some of the consultants are less than collaborative and less than encouraging if you want patients to come on board as partners in the pain management process. Worth thinking about, just points that are worth bearing in mind.
Thank you, Tim. The QR.
Can I just step in? Sorry, Satish, just to say that I've just put up these two tools. So our health check, and we've also got like a medicines check on Live Well with Pain. The health check is actually now available online. So if you go to the website, you can actually fill it in online. We don't keep any of that information. That is for the person who's completed it to keep. And they can go back and repeat it over time and see how they're progressing. So, if they're trying to adopt some new self-management techniques, they can go back and sort of gauge their own progress. So it's giving them ownership over that. And that's something that I encourage people to fill in and then bring to their appointment. And, there are other tools like the Navigator tool from Pain Concern is a similar idea about taking this with you and saying, this is what I want to talk about. These are the things that are affecting me. This is how pain is impacting the things I want to be able to do. And from a practitioner's perspective, it's really helpful because you immediately, particularly if you're short on time, it focuses your conversation. So you are more likely to get a collaborative result from that conversation because the person is coming to you saying, these are the things that I need support with. If you go to the health check, you'll see that some of it are things that are not within the health services gift to resolve, but that enables the practitioner then to see, well, actually, this person would be much better off seeing our social prescriber, our health coach, putting them in touch with third sector organisations, that sort of thing. And this is how you build that collaboration and understanding with the person. And there's a similar thing with the pain, with the medicines check. It's around seeing how the medicines are helping that person to do the things they want to do. And I have been involved with NICE guidelines. And so I sort of understand the frustration when you've spent a lot of time debating the nuances within it, and then you see none of that reflected in practice. It's very frustrating. But certainly with that NICE guidance 193, the idea of that was to ensure that where medicines are helpful, people continue to use them because they're helping. But we need to be better at helping people to demonstrate how they're benefiting them. And also for practitioners because there is an onus on us to keep things safe, but we need to be able to demonstrate we've asked the right questions, and the medicines check perhaps might be helpful if you're looking for ways of just doing that more effectively.
They're both in the chat.
Yeah.
Thanks,
Links are in the chat.
Thanks, Rachel. Yeah, that has been put into the chat by Rachel, and some more information regarding an article in BMJ from Stephanie. And Tim wanted to add something to that. Please go ahead, Tim.
You would expect me to say this as a wordsmith. I think I counted 7 uses of the word person in Emma's last answer to that point, which is it hits the nail on the head perfectly. You know, you're not treating a condition, you're not treating my lower back pain, you're treating me. You know, that holistic approach is absolutely essential to long-term pain self-management. Without that, you're going to get nowhere. We're not problems, we're people, and we're, you know, people with problems that you can help us solve.
Yeah. Thank you very much. Now, the QR code is on the screen for the participants to fill it in. And while that you do that, I'm just going to ask one last question. If there's nothing there, just one for Rachel. I think you talked about in your talk about restorative sleep, which can be very, very difficult when patients are whether in acute or chronic pain, mental health problem, and depending upon the Z drugs or other things, using medications plus alcohol or other stuff. So it's quite difficult and becomes quite a catch-22. They're hoping for these things to give them a sleep rather than a restorative sleep, and that becomes quite difficult to explain to them at times. So any thoughts about that, please?
You're absolutely right, Satish, that people often turn to an awful lot of things to try and get to sleep, and sometimes it's bringing the thoughts to what does the restorative mean, what is sleep, how do we need it, and just bringing people back. So the live well footstep around sleep is a little bit of bringing some understanding, ridding myths, and also it looks a little bit more at sometimes this idea of sleep is also based on what you're doing during the day, and how you live in the day affects whether you're able to sleep and whether you get restoration from it. So it takes a much more holistic approach in acknowledging that sometimes daytime changes, whether that be what you do, how you think, how you approach activity, might also help you when it comes to sleep. So another tool, another way of us being able to introduce that footstep. But it's also around getting rid of some of the ideas that you can't fix everything all at once, a little bit like Emma's approach when it comes to medication, that don't try to fix everything all together. Take small steps in being able to change the way that you approach sleep so that you do things in a small way rather than trying to change everything all at once. So it might not be the case of, I have to get rid of everything, I have to sleep properly. It also takes away some of that fear and anxiety that I'm not doing it right. And that makes a big difference as well. So again, I'd point people to the footstep to look at it as a much more holistic thing rather than something on its own.
Thank you very much. And I read somewhere that sleep starts first thing in the morning when you wake up, exposing yourself to the daylight, whether it's even if it's
absolutely
winter time, there is lack of any daylight, but just whatever you get going out into the light to stimulate your brain. But thank you very much. Thank you everyone for that excellent talks and discussion. And I don't see any more questions in our Q&A. And thanks for posting all resources into our chat function. And if I'll ask the participants if you could please fill it in our evaluation form. We'll be really grateful for that. Thank you very much, everyone.
Thank you.
Yeah. So I think Joe wants us to wait till the end. Yeah. So it starts with, while we're waiting, I'll start with my QR code. Oh, it's asking to sign in with Google account. Okay.
I'll check on that. I did a test and it didn't ask me to log in. So let me just check. If you can't complete that tonight, don't worry. I'll send an email with the recording and with the evaluation form for you to
Thank you,
complete.
Joe. Yeah, because it's asking to sign in with the Google account.